I'll try and speak up so that you don't have any trouble hearing. Can you hear me all the way in the back all right? Good. This is going to be a very biased talk. I'll tell you that right up front. And one of the slides I'll show in a minute is timing is more important than anything in the evolution of mechanical ventilation. And in my career, that's absolutely true. I trained at the University of Florida, and one of the first therapists I met was Dave Desautel, a giant in the field of respiratory therapy that probably few have heard of. But he taught me how ventilators work as a resident. And then shortly after I developed an interest in mechanical ventilation, and we developed a ventilator that allowed patients to breathe spontaneously between mechanical breaths, IMV, I ran into Ron Sanderson, who was running the local school for respiratory therapy. And he invited me many times to come and lecture there. So my career really began with a close affiliation of respiratory therapy. I'm still the medical director of a community college program in Tampa. So I feel I have a warm place in my heart for respiratory therapists and the people who have to put up with physicians who don't know what they're doing with mechanical ventilators, which is unfortunately quite common. I'm also very fortunate to have followed Dr. Daxon talking about APRV. It makes my life a whole lot simpler because a lot of times people don't have any clue about what APRV does and so on. It's considered by many to be a new technique. I actually got a patent on APRV in 1987, so we're rapidly approaching 40 years ago. It actually came about very shortly after so-called pressure support ventilation. And there are a whole lot more studies on pressure support than there are on APRV than there are on pressure support. So timing is absolutely important. One of the first articles that became of interest to me was by Alvin Barrick, the so-called father of oxygen therapy, who described the use of a vacuum cleaner with a hose plugged into the back end of it, so it was blowing out air, past patients with a mask on their face to develop what he called CPPB, continuous positive pressure breathing. We would call it today CPAP. So mass CPAP actually was well known in the late 1930s. And then Thomas Burford, who I was fortunate to listen to when I did an externship at Washington University in St. Louis. He was the chief of thoracic surgery. I discovered later published a classic article on what he called traumatic wet lung. Now, this is an old slide. It's a PowerPoint slide now, but it didn't used to be. And I kept it the same so you could see how old the slide is. These are all the different names of what we would call ARDS today. It's been around for a long, long time. People give it different names in order to give them a different perspective on treatment and so on. But Burford said, regardless of what caused the lung to be injured, the mechanism by which the lung might be able to cope with a primary lesion is deranged. The lung is harmed. That mechanism has to be restored. You have to restore the lung to its normal physiologic condition in order for the therapy to work and the patient to survive. That was very insightful in 1945. And then Nason Jensen, who was not at the Mayo Clinic, but who was a surgeon in northern Minnesota, published an article on diseases of the chest. Now, his numbers are off, if you'll grant him. He confused centimeters of water with millimeters of mercury. Give him a little bit. He assumed that the pleural pressure was equal to atmospheric pressure, what it's not. But he assumed if the lung was damaged, if you put 4 centimeters of water, CPAP, on somebody, it would cause the lung to inflate, and it wouldn't collapse if you had injured ribs. This was the device that he used, and it was very insightful as well. It had a humidifier, bubbled oxygen through it, 10-liter reservoir bag. I've asked lots of therapists, why would you want a 10-liter bag? I have never gotten an answer yet correctly from anybody. So if you can give me an answer later, I'll give you credit for it. But it was because a 10-liter bag has a compliance such that at a pressure of 4 centimeters of water, when the patient took a breath, the pressure didn't change. So it was a constant positive airway pressure. And he thought of that at that time. Basically, it was a demand valve. And with that, they could then decrease the minute ventilation going into that bag or the flow going to that bag to the minute ventilation of the patient. Very insightful, considering that that was over 75 years ago. What happened? The trajectory should have continued from there, and it was polio. All of a sudden, there were patients who had normal lungs, but they couldn't breathe. And in that case, they needed to be mechanically ventilated. Now, I want to take a little bit of a digression here to quote somebody well known. It's difficult to identify the who and the where of advances in medicine. Absolutely true. It's rare, indeed, such as the use of digitalis by Withering, that can be clearly related to the astuteness of one person at one time in one place. It's easier to identify the who, when, and where of some delays in progress along the frontiers of medicine. Some of you probably think I'm going to talk about Tom Petty, and I will in a few minutes, but not yet. To become a who held up the advance in science, one must meet certain criteria. First of all, the scientist or the clinician must be highly respected, an eminent authority, a Geheimrat in some field. He must have strong convictions. He must not hesitate to utter these forcibly. And he must, in this instance, be wrong, although he surely doesn't recognize that he is. Fortunately, all 5 components must be in the recipe or it won't work. It's going to be very hard to eliminate the first 4 components. The hope for the future lies in eliminating the last of the 5. Dr. Daxon, I thank you for that. Hopefully you're that last person. That's Julius Comro in the 1960s. So what happened with CPAP? Clearly it worked. Clearly it was effective. And it was Andre Cournon, a cardiologist, highly respected in New York City, that had an ongoing academic debate with Alvin Barrick. They didn't like each other. One was a cardiologist, one was a pulmonologist. They both took care of patients who had pulmonary edema, but they had different ideas about how that should happen. And Cournon wrote, "It would seem to me that the crucial thing is to use equipment that'll give the least reduction of cardiac output. In my opinion, from that point of view, respirators such as the Bennett X2 are probably preferable to continuous pressure breathing, or CPAP." This is the Bennett PR2 to which he was referring. It had not yet been there. Some of the therapists in the audience, maybe one, is old enough to recognize this IPPB device. It's a flow cycled mechanical ventilator. It gives positive pressure ventilation. That's what it's for. Cournon did a study and showed that if you retarded exhalation to create PEEP, we would call it today, it decreases cardiac output more than CPPB or CPAP, we would call it. Now, another aside, this is a slide provided by Siemens. And if you have an ideal flow resistor, as you increase flow, you would get an increase in pressure on the left axis. And you can see that the Siemens fully open exhalation valve with higher and higher flows looks almost like an ideal flow resistor. This caused great problems for Siemens in the mid-1970s. Patients who were trying to breathe spontaneously on the Siemens machine had great difficulty because if you added enough inspiratory continuous flow, you had very high levels of CPAP, if you will, and on inhalation, the pressure fell significantly. So they developed pressure support ventilation in order to overcome that. One of our ex-colleagues, Mike Banner, gave me this slide some years ago. On the left-hand side, you see the Puritan Bennett PR2. I'm sorry, on the right-hand side, the Bennett PR2 flow-cycled ventilator that is triggered on by a patient inspiratory effort. You can see below the flow, and you can see that the flow terminates at approximately 75% of the inspiratory flow, and then the tidal volume below is 500 milliliters. On the left-hand side is the Siemens with pressure support. In other words, they're identical. Pressure support is just flow-cycled mechanical ventilation. I went back to the University of Florida to teach in 2008, spent 5 years there in the anesthesia department and critical care, and every single resident had been taught that pressure support is a form of spontaneous breathing. And it isn't. It's patient-triggered mechanical ventilation. Now, you can set the level at 3 centimeters of water, and it's not a lot, except if you have a normal patient with normal lung thorax compliance, it will give you a tidal volume, in that case, 3 centimeters of water, 300 milliliters. And it's no wonder that a lot of people who are weaned to pressure support, say at a level of 4 or 5, suddenly fail when they're extubated because they've been getting mechanical ventilation, perhaps at a rate as much as 15 or 20 breaths per minute. So when I weaned patients for those 5 years that I was in Gainesville, none of them ever got pressure support at the end of anesthesia or during breathing. If the resistance of the endotracheal tube meant whether they made it or they failed, I wasn't concerned. So let's go back then to phase 1. Before 56, patients were ventilated because they needed to be mechanically ventilated. They couldn't breathe on their own. And then with the poliomyelitis epidemic relatively obliterated by the Salk and Sabin vaccines, controlled ventilation for postoperative trauma using a ventilator by Trier-Merck became pretty much the standard of care, and that's what I inherited as a resident in the late 1960s. And Trier-Merck reasoned that if you had a patient with a flailed chest, every time they inhaled, the flailed segment would go in. Every time they exhaled, it would go out. But if you put them on enough mechanical ventilation to overcome their desire to breathe, in other words, control their ventilation, on inspiration, the flail segment would go out, and then with passive exhalation, it would go back in. There's a typo in the original manuscript that I've typed in inspiration. So after 1968, Ashbaugh, a resident in surgery, and Petty described the use of what they called CPPB. Alvin Barrett called them and said, no, CPPB is different. I coined that term almost 30 years ago. So they changed it to CPPB, continuous positive pressure ventilation, mechanical ventilation with PEEP. All sorts of caveats were there. You can't go over 12 a PEEP. You'll get pneumothoraces, cardiac output will go down, and that's what I inherited. But the other thing I inherited was a visiting professor at the University of Florida, Bob Kirby. Bob Kirby had just developed the baby bird ventilator. I was told by Ron yesterday that Forrest Bird said that was the greatest ventilator he ever made. It probably could be considered the responsible for the survival of literally thousands of infants with idiopathic respiratory distress syndrome. It basically is a continuous flow device that is interrupted by a bird exhalation valve periodically, timed by a bird anesthesia ventilator, that little block up in the right below the E, so that the infant would be mechanically ventilated. But because there was a continuous flow of gas, they could also breathe spontaneously. So we all looked at that and said, this would be great if we had adult patients. Trouble is, you can't put, in those days, 120, 130 liters per minute through a circle so that they could breathe spontaneously. And then even if you did, when you close the exhalation valve, they would suddenly be blasted with 120 liter per minute inspiratory flow. It would be quite uncomfortable. So we developed IMV by using a one-way valve that would allow the patient to inhale. But before that, I had a patient who had been broadsided, a professor at the university, broadsided by a drunk driver. And at that time, as I mentioned, we weren't supposed to go over 12 a peep. This guy was in the unit. It was late at night. Nobody would know the difference. The thoracic fellow was there. I said, why don't we put a Swan-Ganz catheter in? I had just learned how to calculate shunt and AV difference to reflect cardiac output. So we did it. We didn't know you're supposed to use a pressure transducer. So we did a cut down in the arm, threaded the thing up, and took about 12, 15 x-rays until we saw that the catheter was in the pulmonary artery. Calculated shunt, AV difference, titrated the PEEP from 10 to 12, 14, 16 to 18. At every single level, the shunt went down, the PO2 went up, and the AV difference got smaller, indicating an increase in cardiac output. That was until we went above 18, and then the AV difference didn't change anymore. So we left it at 18. Presented the case next morning. Nobody could explain why cardiac output would go up. Jerry Modell, my chairman, said, why don't you collect a series? So I did, and it was published in 1973. And we found that the optimal PEEP level for decreasing shunt was actually 13, not 10 at that time. Our survival rate was 25%, pretty dismal. But you could see with a shunt of 50%, the PF ratio was less than 100 in every single patient. So these results are essentially identical to ARDSnet today. And then using partial ventilatory support, a term that Barry Shapiro invented with IMV. And now enters Tom Petty. Tom Petty read the article, published an abstract in Chest, IMV versus IMC. He said that intermittent mandatory cerebration is therefore the preferred method of discontinuing mechanical ventilation. Even better, continuous mandatory contemplation must emerge. In other words, if you used IMV, you weren't capable of thinking. I mean, that's hard to believe that kind of rhetoric was going around at that time, but it did. And Tom Petty was, in fact, the Geheimrat. Now, why is that? Why are people so adverse against APRV? It's been around now for almost 40 years. Neophobia is a maladaptive coping mechanism that when confronted with a new experience, the fear response exceeds the scope of any realistic threat. And xenophobia is a subset of neophobia. It halts progress, can make it difficult for people to accept new ideas and change. Well, it's not a good idea to accept every new idea at face value. New ways of thinking are critical to success, innovation, effective problem solving. Now, we then set about, beginning at about 1973 to I'd say 84, 85, to investigate the physiologic effects of patients being mechanically ventilated and breathing spontaneously, also receiving lower values of FiO2. And we found in these studies that were published, although very few of them were controlled against another type of ventilation, that you could use higher levels of CPAP, less positive pressure ventilation, fewer mechanical breaths, lower FiO2, less fluid resuscitation, with greater cardiac output and an easier weaning. Now, this slide is very old. This was recorded in 1974 when I was in the military. It's a patient who was receiving 20 centimeters of water CPAP, was getting one intermittent mandatory breath, if you will, every 30 seconds. We were recording blood pressure, and we recorded pleural pressure. At that time, I was actually inserting a catheter in the pleural space so that we could measure with a fluid-filled catheter intrapleural pressure. We didn't use an esophageal balloon because they're not accurate. As soon as the pleural pressure goes above atmospheric, an air-filled balloon is worthless unless you put air in it. Now you're dealing with compliance of the balloon. So we used a fluid-filled pleural catheter. About halfway through that first segment, we increased the ventilator rate, and there's a blow up of that, so that you can see the pleural pressure is going up a lot more often. And you can see up above that the blood pressure that would fall to 75 millimeters during the positive pressure breath and then would return to baseline kept getting lower and lower and lower as the mechanical ventilator began to cause a loss of spontaneous breaths. The spontaneous breaths are indicated by the drop in pleural pressure. At this point in time, I can go over here, where the mechanical breath stops. We don't ventilate anymore. I did that because the blood pressure you see above hit about 55 over 35, and I thought the experiment had gone on long enough. And I turned the mechanical ventilator off. Immediately, with the ventilator off, no mechanical breaths, no spontaneous breaths, you can see the blood pressure shot up to about 70 over 40 or 45. That's with no ventilation. And then if you look down at the bottom where the first big spontaneous breath occurs, you see a dramatic spike in blood pressure back up to 85 over 50. This demonstrates why we were able to mechanically ventilate and still not give tons of fluid to people, and why we could use higher levels of PEEP, and why if you tried to use 20 of PEEP with a mechanical ventilator in controlled ventilation or assist control, it isn't going to work. The patients won't tolerate it. Now, this is another slide that shows a patient that's getting the one mechanical breath every 30 seconds up on the top. Sadly, we were using a bird exhalation valve, which has high flow resistance. So that explains the spikes with spontaneous breathing. And you can see it, 10 millimeters of mercury. We used millimeters of mercury so the surgeons wouldn't know how high the level was. So it was really 14 centimeters of water PEEP. And you can see the pleural pressure is actually, during exhalation, about 8 millimeters of mercury, 10 centimeters of water. That means that during exhalation, the transpulmonary pressure, the difference between airway and pleural pressure, the pressure keeping the lung open, was only 4 centimeters of water. We removed the CPAP, and you can see immediately airway pressure went to 0, pleural pressure went to 0, so now the transpulmonary pressure is 0. There's no pressure inflating the lung, and you can see the patient's dropping pleural pressure as low as 19 centimeters of water. That's where you'd see pleural retractions, nasal flaring, and the patient's respiratory rate, of course, went up above 30 millimeters of mercury. Now, a patient breathing with retractions, breathing 30 times a minute, hypoxemic, those would be patients that are mechanically ventilated. The question would be, in this instance, would you mechanically ventilate that patient now, or would you just put the CPAP back on and let them breathe, obviously very comfortably at 14 breaths a minute? And that, of course, is what we did. Over to the right, it's interesting. You see a shallow breath and then a deep breath, shallow, deep. And that's respiratory alternans, a sign of diaphragm failure that's been reported. Again, that occurred in less than 1 minute after removing the CPAP. And of course, when CPAP was put back, the so-called diaphragm failure was resolved. Work of breathing is the area of the triangle on this pressure volume curve. So when a patient develops a rightward shift in the PV curve, you can see the work of breathing for the same tidal volume increases. In order to reduce the work, the tidal volume goes down, but the rate has to go up to get rid of CO2. The solution by many has always been to intubate and ventilate such a patient. Our solution beginning over 50 years ago was just to increase the CPAP level to try and return the FRC near normal and reduce work of breathing. When I went to the Air Force, we collected a group of patients who received so-called high-level PEEP. All of them received more than 20 millimeters of mercury, 27 centimeters of water CPAP. There were 54 of them. They weren't all old retirees or young soldiers. Average age was 38. Highest was 83. Youngest was 4. Initial shunt was 35 plus or minus 6%. The initial PF ratio was 85. All these people had severe ARDS. This was the same time the ECMO trial was going on in Boston. Their survival rate was less than 10%. This was one of the victims. This is John Grachala and his wife. They were riding a motorcycle over an interpass in San Antonio, Texas. And one of the corpsmen went by this motorcycle and saw it and took a picture of it, didn't realize it was one of our corpsmen. So this is a picture of John and his wife 6 months later when we brought him back for pulmonary function tests. John had severe ARDS, was treated with high levels of PEEP and so on. Ramona was in the emergency room, got intubated. She had a fractured pelvis. She didn't have any problems with her lung. But just less than 24 hours of being intubated with a high pressure cuff tube was enough to create tracheal stenosis, so that she had to have a tracheostomy tube. And that little kid, you could see, is kind of wild. Her biggest problem was a fractured pelvis. She couldn't yell at him and she couldn't chase him. And her husband had to go back to work. You see the pack of Marlboros in his shirt. So in spite of that, his pulmonary function tests were pretty normal. Our optimal PEEP level averaged 37 centimeters of water. Shunt level, 14% at that level. The PF ratio, as you can see, was in the range of 300 to 400 millimeters of mercury. The average time of intubation was 5 days. We had 4 pneumothoraces. All of them occurred when we were using bird exhalation valves. When we switched over to an Emerson PEEP valve, the pneumothoraces stopped. Our survival rate was basically 80%. And I'll come back to that 80% level later. So looking at the use of spontaneous breathing combined with controlled mechanical ventilation, we were able to show that ventilation perfusion relationships are improved, cardiac output is, work of breathing can be reduced with CPAP, and I believe our outcome was. So I would say, reflecting back on all of this, the only thing that's new is the history that we don't remember. And then I'll start basically from here to say, why APRV? Why did we feel that that was important to develop? Thank you very much. Be happy to take a question or two. I ran over a little bit, I think.
Dr. Dunn, great. It's just any questions for Dr. Dunn? I know this talk